Good morning and welcome to our monthly webcast. I am Samir Mehta, your moderator. This is session number 62 and I'll take you through an exceedingly complex coronary intervention. You're going to watch multiple imaging modalities including OCT and the use of left ventricular support devices, probably with the Impella device, but that decision will be based on the judgment of Dr. Kinney and Dr. Sharma. Sameen, good morning.
Yes, good morning.
This is a difficult case today.
Yeah, well, I mean, it's a lot of challenge in this particular case. It's not only the whole issue which we will discuss, appropriateness and so, but yes, sometimes, these kind of things encounter in our life. You have the dilemma, but I think it will be a good one, lot of discussion, not only just the case, that how to selection about the case. If it's okay, we can just go ahead and go through our process. If we can just go the slide, basically some disclosures. This is a 62-year-old patient, actually 59-year-old patient who has a BMS after LAD-MI in January of 2003. Remember, the cipher came in March. So it was in January 2003, and he had a BMS at that time to the mid-LAD, and he did good for last 11 years until recently when he started having chest pain, class II angina, and they did stress test, and he has a cavity dilatation with multivessel ischemia. And clearly led to the cath, which I'll show, with the 2 vessel and left main disease with the CT of the RCA and left main and other vessels, and ejection fraction was 25%. Now, we actually saw his EF has been around 28-30% for last 10 years, and he was okay on that. But now slightly more decline from 30 to 25%, and so that clearly patient then when came for cardiac cath, we are expecting will have a left main and significant vessel diseases, so that this case is the right case for coronary artery bypass surgery. And of course, he was well controlled on various medical therapy. Now, what I want to do is, Anu has taken the picture that we just take this case. This is the right coronary, mild disease proximally, distal RCA was total. And then the more important is here, you see the distal left main disease, and that the circ is mild to moderate. But clearly the ulcerated lesion of the mid-LAD at the site of the bare metal stent. And the question is, how can you develop ulcer in an in-stent restenosis? And I'll ask our expert, Dr. Kinney, to talk about that, is it a neoatherosclerosis and what will require to make that diagnosis. But clearly the ulcerated, the in-stent restenosis usually is not ulcerated. Clearly here looks like a ruptured plaque, but we know there is a bare metal stent in that area. But more importantly, that in addition to this, this patient actually has very low ejection fraction, about 25-28%. So rightly so, with this kind of case, there is, the recommendation is straightforward: CABG, 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 because of which will show survival advantage with a syntax score of 34 and left main disease. But the patient, because of history in the family, the family dying after bypass surgery, absolutely refused bypass surgery after discussion with the cardiologist and a surgeon. So this is the case where heart team discussion took place using involving his referring cardiologist as well as the bypass surgeon, where I'm not part of the discussion, and then decided that we need to do an intervention because patient refused absolutely, and that led to patient here today. And this is where we are. Now, if you go into the appropriateness use criteria, it will not fit in because the left main is still, we have the old one, updated one still required to update. The left main does not fit in, but of course, in the appropriateness use criteria, that left main with a syntax score of less than 33 or more than 33 puts into U and I. But more importantly, what has been shown that heart team discussion with refusal to CABG, I would say will make it at least U. And we know that based on the guidelines, clearly that the CABG has shown to improve survival in these patients. And then of course, the PCI can be done. in particularly patients who have a high, will be 2A, if patient has a high comorbidities. In this case, ejection fraction is low. So whether that will alone, but I would say 25-30% surgeons do those surgery without any problem. In this patient, his operative mortality, STS based on will be, was about like under 2%. And those are the guidelines of the 2 and 2B. And of course, 2B is when it is lower risk in terms of STS mortality and patient has advanced coronary artery disease. So clearly, we have big dilemma that ideal case should not have, should go for bypass surgery, but for various reasons, the patient decline after discussion, and that's where we are. And I'm sure, Samir, there may be questions about it.
Samin, one of the questions which comes straight to my mind is 59-year-old, if this was your brother, would you dissuade him from surgery?
Oh, I would absolutely will PCI convince him. Yeah. My recommendation number 1, number 2, number 3 will be a coronary artery bypass surgery for a long run. But we have patients which will say that I may die, but I would not go for surgery. Rare cases, and this case fell into kind of that category because clear my recommendation. Now we are done unprotected left main with this syntax score or even higher in many patients, but those are usually septuagenarian, octogenarians, and nonagenarians. I would say that that's where the CVA clearly has shown occur higher in the CABG group compared to the PCI group. Although overall even freedom taken all patients together, CVA was higher while there was a mortality advantage. So that to me, I think maybe a point we can make for only for the elderly patients. But in this kind of young patient, I would say that CABG it was a big moral, ethical, and practical dilemma what to do. And clearly, we don't want to decline patient from the appropriate care, and we knew that this patient has a very high risk of subsequent event because of low ejection fraction as well as the high and the multivessel ischemia with the cavity dilatation, and the decision was made for this, kind of you can say reluctantly, but key is that after adequate discussion with the patient. And the family, actually all families involved. Like even this morning, there are 4 family members here this morning with this patient.
Samin, the proximal RCA also looks to be having significant.
Yeah, mild disease. Actually, it is there, moderate. That was back in 2000 also, 2003. So that remained kind of same. So we didn't touch that. So I said, let's do a less stent rather than more. And then we put a 2 DES there in the distal RCA, and we left the proximal alone. And this remained the same way. And whole case is clearly that this issue of the distal left main and the LAD and at present.
I am sure you are considering some form of left ventricular support here.
Well, I mean clearly that in this case, I would say the error should be close to 0. Error basically means that ability to take care of any of the complex procedural complications, so that how can you be better prepared? And what has been shown in the studies that by using the Impella assist device gives interventionalist that armamentarium to deal and do your job well while in these complex cases. And therefore, I think that is where we felt that it's an appropriate case for Impella.
Excellent.
Anna, AK? Do you want to say any further point what we are doing and where we are now?
Yeah, with this LV function, I think we got EDP just about 14. So with the, if you see the EF just between 25 to 30, we have Impella device ready to go. We have the new
enhanced Impella CP.
Yes, Anu, take us through that. What are the changes you have noticed? The Impella device was one of our first devices when we began this telecast a few years ago.
Yep.
I'm sure much progress has been made.
And particularly with the CP, which can get you the cardiac output up to 4 liters.
Excellent. Yeah. What about the profile size now? And
no, profile size hasn't changed. The catheters, this one is still 9 French. The sheath size hasn't changed. What they have done is the inlet cage, the length has increased, and then what they actually did was this outlet cage, which was probably closer to, which is going to be was closer. They moved higher up.
Right.
If you see that. Those are the 2 important things that they have made.
As it is, this is an extremely user-friendly device, but
Yeah.
these enhancements, I think, only help. What about the console? Any improvements in that?
No, console actually they change it. I think in the past, which is the same. And like I told you, if you know English, the console will tell you everything how to do the Impella.
Yeah.
Not in Spanish.
But it's a very simple, that is the whole thing, that from interventional perspective, you want something which is easy to understand and easy to navigate.
So, Samin, I just checked. Our first case was done on July 21st, 2009 with the Impella device.
That is correct. We started the webcast with the first case with the Impella.
So during those days, it was mandatory to perform LV function analysis with 2D echoes. Do you do those things still?
Well, I think particularly somebody who has anterior MI, it will be reasonable to do echo just to see that there is no
LV thrombus.
There's no LV thrombus. Yes.
How much are you concerned with any aortic valve disease? Not much?
That again, if it's a severe aortic stenosis, will be the issue. But valve area up to 1.2 and above, in my opinion, you can use the Impella.
Would you? I know you are talking about some new left main indications and OCTs. You'll give us a little update on the scientific trials with the Impella also?
Yeah, well, I mean, not today. Today we gave.
We can show you the console.
But here is basically I think we just have a multiple publications from our original Protect 2 trial that more complex disease, Impella had a bigger benefit compared to balloon pump and so.
So see, we inserted the Impella. It's in the LV. You can see that.
You'll take us through the levels. Is it P2, P3, P4?
Yeah, you can see it. I think it adjusts by itself now.
Okay, 2.7 at the moment.
And it will go up to 4.
How much would you want? Is 3 enough or 4 enough? Or?
Yeah. In this particular case, I think we'll be okay. We get about 3.5, because patient has a good cardiac output, is a young patient, and this is kind of done more prophylactically, so that in this case, again, same. That we know last year in June case, patient who had bypass surgery, left main closed, and patient has a major catastrophe.
Right.
So you want to be able to deal with all those issues proactively, and this is one of the indication of the Impella in this particular case.
You have a swan in place?
Well, that's another point, that what we learned is that anytime you do vein, you increase the vascular complication, and if the EDP is high, then you may decide more additional right heart cath. And so in this particular case, actually EDP was low. It was 8, and we are trying to give him more fluid. His blood pressure is barely 90 over 65.
Some people would argue that is another reason to actually put in a swan, no?
Well, I mean, particularly if the pressures are low, you can always, we have the venous sheath, if need to be, we can always do. But anytime you have this vein, bigger sheath may have a higher complication, vascular complication.
So routinely you are not using?
Routinely we did only in the trial at the Protect 2, which mandated. Yeah, okay, how are we doing now in terms of?
Anu, any change in the anticoagulant strategy with the use of Impella?
We still use Angiomax.
Okay.
Yeah. For the trial, it was mandatory to use heparin.
Okay. How is the patient hemodynamically doing all right?
Yeah, his blood pressure just about 100 now.
Samin, this is unrelenting queries about indications here. I'm going to read to you specifically as the question has come, and this has come from Miami.
Yeah.
Dear Dr. Mehta and Dr. Sharma, I would lose my PCI privileges if I attempted this case in my hospital.
Well, I mean, I would say that based on the guideline, that is a right statement, but if your team discussion had taken place, and this is where the whole, actually ACC helps us in this, our guidelines. Guidelines say you can go with the patient preference, but after the heart team discussion, and that exactly has happened with this particular case. So therefore, there is no reason for anybody to lose privileges as long as you have done the right and has documented. So in this particular case, surgeon has documented that we have discussed with the patient and the family, all risk benefit has shown, and patient agrees. And now what I do in these cases, where are vulnerable, that means there is other choices available, that we do all the routine left main surveillance. Angiography is no longer indicated, but we bring those patients nowadays for angiogram between 4 to 6 months, just to make sure that everything is all right.
Excellent.
Yeah. So in this particular case, this particular patient said, if you want me to come every year for an angiogram, I could, but I just do not want the CABG.
Anu, any cases where you've needed any manipulation to put in the Impella? I mean, this really is just like putting in a slightly larger pigtail catheter.
Yeah, I mean, the cases with the groin tortuosity,
right.
In this case, the patient did have groin tortuosity, and we have a long sheath. It usually comes with the Impella comes with their own sheath for insertion, which is a shorter one. So we had to use a Cook 23 centimeter sheath to go through the iliac tortuosity. Cases have been that patient has had a stent graft and all that. In that situation also, Impella with over the wire, even moderate tortuosity, it does negotiate all these tortuosities.
Also, Anu, don't you think this is also so much of it is moving targets, with the TAVI we are doing now, putting in an Impella device looks so straightforward.
Yeah, that is true. Now, more important here, look at this angiogram. To me, looks a lot of calcium in the left main. We didn't perceive it earlier. Patient never had a left main intervention. We know the mid LAD is a stent. There's some disease in the proximal LAD, but left main is almost moderate plus calcium, and hopefully the OCT, which we plan to do in this particular case, will guide us in that way.
Why OCT and not IVUS?
That's a very good point. In this particular case, I was a little curious about this ulceration in the the bare metal stent, in-stent restenosis, and of course we know that to show the neoatherosclerosis, you need two things. You need a endothelialization so that there is a cap, and secondly that there is a lipid. So in this particular case, of course, the lipid, OCT can tell you lipid, but you really need NIRS for that purpose. But I felt that it will be curious. But yeah, now how good for the calcium?
Any benefit of an FFR here?
Well, FFR probably won't help. Here is clear.
You've got a solid information from the thallium.
Yeah, we got the info. Yeah, this case FFR will not add any because it's a very high risk scan, and angiographically it's not a borderline left main. And this is where I'll talk about that FFR also. Look at that. This is a 80% left main. I don't think anybody will question or will doubt that there is a significant left main or not. You see that? It's a clear-cut, solid 80+% left main. And we want to say OCT versus IVUS in this particular case?
If you see the ISR, I think like mentioned, if you see here, looks like it is an ulcerated long ISR. To really understand what is the lesion morphology, OCT will define better because it will show you the presence of lipid as well as the cap thickness in this case. So the only thing is coming to the left main to understand the amount of calcium arc. We may not be able to get it. The proximal the vessel is because since the entire dye has to be replaced from the vessel, we may not be able to get the distal left main. But you cannot say we still have more than 10 millimeters. We may be able to get the OCT. Yeah.
Anu, any concerns about advancing the OCT catheter through the tight left main?
We will see that. What happens is as soon as we get the OCT into the lesion, we have to do a test injection. Now, while doing a test injection, if there is dye staining in the vessel and you don't see that the lumen actually is seen in the OCT console, you should not inject. You just take out the OCT catheter.
Because the next will be your ventricular fibrillation. So while
what I meant is suppose we are trying to do the OCT and we know there's dye staining and we are not able to inject, then we will get the IVUS ready.
Yeah.
Samin, you want to proceed with your academic discussion as we...
They'll be able to see it with the OCT. Okay. Don't open to the imaging.
Okay. All right. Therefore, while they're getting ready, you get your OCT ready. As soon as you're ready, I'll come off the discussion. And we are going to wire with the basically run through and yeah. And
the one other thing you need for OCT, you definitely need the assist device.
So you need to inject high volume?
No, high plus with consistency.
High
Manual
flow rate.
will, no matter how good you are, manual will not give you a good image.
It's an excellent
Okay,
point.
while we are doing this, as soon as we are ready for the OCT, we'll come back and we can go with
We are
the...
ready now. Okay. Now after OCT, what do you want to do? Bring the OCT. Now go to this one, bigger vessel rather than a smaller vessel.
Now let's go to the slide meanwhile. So we'll take about 5 minutes so that we'll get this ready. So I'll talk about 2 points here. Update in PCI guidelines for stable CAD and some newer data on the FFR integration during PCI. Some data. Now as you saw that basically we just got the focused update of guidelines for diagnosis and management of patients with stable ischemic heart disease. They call it SIHD, stable ischemic heart disease. So this is the updated as of last week, the guideline because of the various studies which have been published in this field, and now they have incorporated in our regular day-to-day. Now clearly they have gone with the diagnosis that which patient should have a coronary angiography with the class 1, class 2, A and B indications, and basically they talk about even 2B that your stress test could be negative. But if you have a high suspicion, you should go with the cardiac catheterization because we know that all non-invasive testings have their limitation. Also, they say that risk stratification, particularly patients with have a high risk low ejection fraction, patient with a sudden cardiac death, and patient pre-transplant and so forth are important to have a cardiac cath as a risk stratification, not only even the stress test. And this actually is very interesting that they came up with a diagnostic coronary angiography without stress testing in ischemic heart disease where it is beneficial. And these are the various subgroups they have identified. That is a long-standing diabetes with end organ damage, severe PVD, patients with a radiation to the chest, patient with the combination of typical angina, heart failure and pulmonary edema. Patient with heart failure, your stress test may not be good, may be more harmful. Then non-invasive testing tells you multiple abnormality in the ventricle, ventricular function, regional. Probably the cath is most important to make the diagnosis, and also clinicially strongly suspect that a stress test is a false negative because the clinical scenario. And lastly, that ambiguous angiogram and ambiguous stress test, indeterminate stress test, you should do a basically coronary angiography. Now there is a one word, and particularly what I'm just showing the change, that chelation therapy used to be class 3, now it has moved up to class 2B based on the TEC trial, because there was some subgroup like diabetic and so there was benefit, but borderline, so that clearly they had taken out chelation from class 3 to class 2B. I'm sure a lot of people talk about the TEC trial. More important is in this. That is the class 1 indication now. That is a heart team approach to a revascularization. It is recommended in patients with diabetes mellitus and complex multivessel CAD. And more important is that you have a heart team discussion, and then CABG is generally recommended in preference to PCI to improve survival in patients with diabetes and multivessel CAD, for which revascularization is likely to improve survival, means 3-vessel CAD or complex 2-vessel CAD with a proximal LAD where you can put a Lima graft. So this is a change recommendation. So very important now that the patient with a 3-vessel or complex 2-vessel proximal mid-LAD involvement, high syntax score, should have a CAB consultation by a CT surgeon to go for bypass. If they decline after discussion, then only patient should go for PCI. This is a major change, and I'm sure it may incorporate in the reimbursement scheme also, just like you cannot do a, don't do it here, once we be ready. It's very, very important. So this is a very key slide which will change our lifestyle, how we practice management of this multivessel disease. It's very, very important. Now it is based on the diabetes, the freedom trial, as you saw, lower mortality despite higher stroke, and of course these were the more complex cases they take into that equation, that patients had to have a complex CAD in order to get benefit of the coronary artery bypass surgery. And there is a recent meta-analysis of all the studies taken for diabetes showing clearly that all-cause mortality, whether BMS or DES, is significantly lower in the CABG group compared to PCI. So very important, and heart team approach discussion is a centerpiece of it, and they really describe what the heart team approach is. Cardiologist, interventionalist, and of course the surgeon, and they decide and recommend the patient the best treatment. Okay, we are ready? Okay, now we can go back to the fluoro so that we do the OCT and then we'll come back. And to tell us what you're doing now.
No, this is a OCT catheter. If you see, actually, there are 2 points, if you can see that. Let me go on Cine. You'll be able to see it better. So you have the second marker. That's where you it starts, your camera, and then it comes all at 2.1 second, you get a 75 millimeter hole scanning. So what I'm doing is I went just distal to the stent where it is and trying to get the distal left main,
right.
And hopefully we'll be able to get the distal left main. So when you are in there, we just inject a little bit and see. You can see it there. Are you focusing on the OCT? Okay, now.
Yes,
yeah.
we do.
And see, you can see it.
But you need to show the angiogram.
Yeah.
Beautiful image.
Yeah. So now, tell me when you're ready. We go. Ready? Were you able to get the distal left main?
Fluoro.
Yeah, you got the distal left main?
Fantastic images.
No, that's what last time it happened. Patient went
That's
into
okay now.
refib.
And a lot of.
You can see it there?
Lot of.
Teach us a little more about
in-stent.
OCT, what we are seeing, except the very good, nice pictures.
There look to be some ulcerated this thing around 2 o'clock.
So this is now we are the most distal portion here. I think in the angiogram what we said, the ulcer, see that? This actually is
right there,
within the stent. Yeah.
2 o'clock.
Within the stent. You see
Now,
the
based on that,
ulcer.
can you say if there is a lipid core at all?
Yeah.
I know lipid
All
can
this
be
is-
defined sometimes on OCT also.
No, this is ruptured, but then this is at 2 o'clock and 3 o'clock position, what you can see is lipid, but then at 1 o'clock where you see it's well defined, you see that? That is all calcium. So this is the stent, if you can see. This is all the embedded stent here. And then this is the new intima.
But stent lumen still looks okay.
Yeah, but now see here, as you come within again, again there is another rupture there. Yeah, and then if you see, I think this is lipid at 3 o'clock position here. See here?
Right. The yellow
All this
marker.
is lipid. That is.
Now, how do you differentiate that the radiolucent area or whatever OCT lucent calcium versus lipid?
No, I showed you. This is the if you see the edges are well defined, that is likely to be calcium.
Okay.
I can show you where the calcium sharply.
But even if you go to left main, I'm sure you'll
see here.
Yeah, that's the calcium. Yes. Well defined.
And
Beautiful.
then this
Beautiful demonstration.
This one, this is all lipid diffuse here.
Okay. Now go to the left main. Can we see left main now? Because that will may change our strategy in this particular case.
This is still lipid. No?
Yeah. But let's show me what
See this? Lipid. So now going to the left main, somewhere here, right? It's not a big calcium arc there.
Okay. Then we can just use the flex dome
Yeah, see
or
if you-
angiosculpt.
thrombotic. The thing is a little bit of thrombosis.
If it's not a 300 to 70 plus calcium, we can use but although a lot
I
of
think if you go with the quadrant, you see there?
Yeah.
It's that one quadrant, another quadrant. This is some lipid, but less than 2 quadrant of calcium. I think a cutting balloon should be okay.
Okay. Or angiosculpt, one of them. Okay. Very good.
Yeah, here you see it, more calcium. See that? If you see this well-defined border like that,
Wow.
that's calcium.
Though, Samir, any other question about our OCT before we proceed on?
Beautiful images, and I see the wisdom in trying to demonstrate what was happening with the ulcerated plaque, although I think the left main information was as good informed, obtained even with the IVUS. I do have a few questions on your presentation, but you still have a part to finish there, no?
Yep. We can go to part 2 while we are planning to do, but let's ask Anu before, what is the plan now? based on the information of OCT, and so what we want to do?
I think we could just do a cutting balloon and just stent the LAD and then the left main.
Okay, so therefore we do the flextome or angiosculpt of both of the mid LAD as well as the left main.
Yeah.
Will you
So
put
at two different sizes.
Two different sizes. I think we can go flextome, cut the LAD stent, restent it, and then do the go to the
Angiosculpt 3.5 of the left main.
You're going to put a wire across the circumflex?
In the end, maybe when we come down to the left main.
Okay.
So then we go to the next data, which is the newer data on the FFR integration during PCI. Now clearly, remember these are the two flow reserve concept, and which is actually coming back now, which is the coronary flow reserve over fractional flow reserve. The fractional flow reserve is looking at your epicardial artery, and CFR is taking care of both epicardial as well as microvasculature. And this is a basic difference in the CFR versus FFR. And now a lot is coming back with the CFR because a lot of prediction of the disease, particularly MRI, and so that the abnormal CFR is prognostic. Remember, we did a lot of trials in the past using the CFR cases, but now and kind of went away. But CFR is coming back now in management of these difficult difficult patients, and so particularly with the diabetic multivessel disease, and so. Now then, what we know, FAME trial clearly showed that at any cut point, FFR guided PCI is associated with a better event-free survival of the death MI revascularization compared to the angio guided survival. And clearly that the difference persists up to 2 years, and so, and more importantly, that what it does, that when you do basically the 3-vessel or 2-vessel, which was the part of the FAME trial, when you incorporate the physiology, that is the FFR of less than 0.8, that you really change 3-vessel to a 2-vessel or 2-vessel into single vessel, that 86% of the 3-vessel and 57% of the 2-vessel were reclassified after FFR. Many of them became no-vessel disease. So that's a very important point, and that has been shown that FFR physiological revascularization was associated with lower stent use and outcome which we have shown. People always ask, I leave a 80% lesion with a FFR of 0.82. What is going to happen to this case? And we actually have the data up to 2-year follow-up. That penalty of leaving a lesion with FFR of 0.8 is very, very little. More often, the problem occurs that you treated that lesion causing more repeat revascularization or basically restenosis later on. Now, FAME 2 trial, everybody knows, the patient less than 0.8 were randomized, and it turns out to be that once you do a medical therapy of these patients with a FFR of less than 0.8, it does not work. It works only with the PCI, and of course if you have more than 0.8 you can leave alone. More importantly, in the study in the FAME 2, the difference of the primary endpoint of 4.3 versus 12.7 in medical therapy was basically driven by your urgent revascularization. There is a death point 2.7, non-significant, but all was because of urgent revascularization, significantly lower in the FFR guided group compared to the medical therapy group. And now actually we have 5 new publications as shown here, basically which I rapidly go through in this aspect, which have come in last few years to give us update on the FFR integration in the coronary revascularization. One of them was the RIPCORD study, and that is that after diagnostic angiogram, you do FFR, and then you reclassify that almost your the 74% of cases that you change your practice in 26%. 74% remains same before the FFR and after FFR, but 26% you change. Some of them actually you did the intervention, sent per patient for bypass, and so because angiographically might have told you a lower angiographic lesion. Then second is the French multi-center FFR registry, same that clearly the FFR guided PCI with a 1-year follow-up. More importantly, happened that what you decided at time 0 and after FFR, that you end up in changing in almost 1/3 of cases your subsequent strategy. Then the second, the third publication is in 4,000 coronary stenosis FFR, and there is a discordance that many of the more than 50% lesion have a FFR of more than 0.8. And more importantly, as you can see in this, the quadrant of the left main, that many of the left main cases, which is the upper left quadrant on the right side, that you have a less than 50% stenosis, but your FFR is less than 0.8. So very, very important finding that particularly left main, your angiography may be very, very deceiving. Then lastly, this is a paper from Mayo Clinic about talking about the long-term outcome with the FFR guided PCI in 1,000 patients compared against 6,000 plus with the angio guided, and they showed actually there is a lower mortality in the FFR guided PCI and of course lower MI, which we always knew. And more importantly, in this particular case, the latest paper which we have is from the Pan London registry, and talking about the patients have a PCI based on the angiogram, IVUS or FFR. And you see here, this is the key slide, that the long-term survival anywhere between 3 to 5 years. In these patients, the MI difference with the FFR guided, although they were done in a small percentage, was no difference, nor with IVUS. Urgent PCI, no difference, but clearly there was a trend towards lower in-hospital mortality with the FFR guided PCI. Now also, you see the procedural complication. FFR guided PCI has a lower procedural complication compared to angiography or IVUS. Why? You use less stents. Very simple, and of course the lower in-hospital stay and lower stent use. So clearly it seems to be that FFR allows you to use lower stent. Only difference is there was no difference in mortality in the long term. There's a slight trend toward lower mortality, as I mentioned, in hospital because of lower procedural complication. But on the long term, there was no difference in mortality, IVUS versus angiography. And that actually had led to, in European guidelines, which are always ahead of us, have used the FFR now as a class 1 indication based on both the DEFR and the FAME, that you can leave the lesion more than 0.8, no problem, less than 0.8, irrespective of the stress test, irrespective of the medical therapy, should get the PCI. And I expect our focus update we just got for the stable ischemic heart disease, but update on the OC criteria will incorporate FFR in United States also as a class 1 indication. So with that note, I think we can just quickly update us what is going on.
Samin, a quick question for you. This is from Dr. Gomez in the Dominican Republic. Could you do this case with the balloon pump? We kind of talked about it, but please address it right.
I mean, clearly that remember one of the big difference in the PROTECT 2 trial where this kind of patient, I mean, this patient would have been randomized in the PROTECT 2 trial. It was ideal case for randomization in PROTECT 2 trial. And what we found in that case, that you do a better complete revascularization using Impella device compared to balloon pump. And that also led to lower repeat intervention. That's the key, despite in the rotablation group. And that's why I would say that, yes, if necessary, if I don't have Impella, yes, I can do this case with a balloon pump, but Impella will give me more moral support and able to do a complete revascularization, which is very important in this young person, that he comes out of here without any complication and get the best revascularization.
And your the basic fact is the severe impairment of LV function.
Absolutely. But this is a classical case of PROTECT 2 trial, which we evaluated.
Okay.
And you tell us now where we are, what you did.
So we did a cutting balloon. We took a 3O flextome and just did the cutting balloon of the LAD. So the proximal edge of the stent looked like it had not opened, so I had to go back and do it. And one of the
expanded now.
Yeah, so one of the same, we went up to 3O to 14 atmospheres multiple times all through the stent.
Did you use it for the left main also?
I did not use it for the left main because we have
for whatever reason.
Probably better integrated flow now. Yes.
Yeah. Now we just have a 3.5 angiosculpt for the left main.
No, but do you want to just put a stent in the LAD first or no?
Let's do the left main because the stent we may have.
Would you dilate with the balloon or put in a small stent 2.5 distal to the previous stent also?
Yeah, there is a one further down. I think that we need to see. And the downstream lesion.
But it's so diffusely diseased.
I think you want to leave it. Lesion. There's one discrete lesion there.
Right there, at the small diagonal.
2 to 5 maybe.
Yeah. Maybe we'll see. No, we're kind of 2.5. But well, let's see.
But then you want to cover the entire diag. Up to the diag.
Yeah. So I think we put a lesion in the mid LAD, we put a stent in the left main, and then they decide if it needs any extra work for the distal lesion.
So
and
now we are going with the angiosculpt for the left main.
It's a 3.510 angiosculpt for the left main.
You want to see where you keep placing it? No. Caudal or no?
No, that's fine.
Okay.
Okay.
Go up.
Yep. So this is the angiosculpt, 3.5. Here we can go to high pressure, and we are 16 atmosphere.
Patient tolerating well?
Very well, yep.
How would you think it would be without the Impella?
No, I would say that this one definitely will have an impact.
Okay. How much is the cardiac output now?
What is the
Impella
cardiac?
output,
Impella
3.5.
augmentation?
Yeah.
3.5, okay.
Yeah, actually it has not fully expanded.
No, I think we have lower
I'm going to
surface.
20 atmosphere on the angiosculpt now, 3.5.
No, it does. If
Okay.
you need anything, you need 4.0 now.
Yeah, 4.0.
3.5 has done the job.
Yeah, but then 4.0 will be flexed on.
Anu, have you noticed, I mean, in incrementally it appears a major gain between 2.5 liter augmentation to a 4. Have you noticed clinically?
For the augmentation,
Yeah, the higher augmentation with the newer Impella, does that make a difference or?
I would say that patient with a borderline hemodynamics.
only.
whether-
I
don't
mean,
know
if
when
we are
this-
talking EF of 20 and less,
Right, maybe then.
those kind of
Yeah,
patients.
maybe somebody with a heart failure, borderline hemodynamics.
You need a EDP of
Yeah.
30,
Yeah.
real
Samin,
sick
I have
patient.
two questions on the heart team aspect.
Yes.
First being, your surgeons obviously spend probably half an hour with this patient and the family answering numerous questions.
Absolutely.
Do they get paid for it?
Yeah, of course. They do their consultation and then they write that of the half hour or 1 hour, 50% left with the discussion, because you don't document that big type of discussion. So that is where the nowadays our reimbursement guidelines, looks good. We'll go to
Now,
that.
there are still some institutions which perform
Yep.
PCI without
Heart
surgical
Heart rate went
standby.
up and blood pressure went
yeah.
down. When we were doing the left main, actually his heart rate went up. Right now is, we he gave back to about 50 or so. But otherwise, he became hypotensive and tachycardic when we were doing the left main dilation.
Yeah. Okay. Now, question is how much we need to do and coverage here. We are ready for the stent in the mid LAD first. And I think we should do it from septal to the second diagonal. Third diagonal. What do you think?
3.0.
Yeah.
33.
3 or 32?
32, okay. Samin, so the question is, there are
3 or
still
32.
there are still a few hospitals which perform PCI without surgical standby.
Yeah. Oh,
you-
yeah.
you may
Actually, I
not-
think everywhere now. Yeah.
Okay, so a lot of them don't even have cardiac surgeons in house. How do you create a heart team?
Yeah. Well, that's a very good point. It goes back to the same.
They
that,
go back to their
the guidelines. The guidelines are this kind of patient, like we have a Lutheran Medical Center or Elmhurst Hospital, this kind of patient cannot have a PCI at that place.
Yeah, they have to go to the tertiary care center, refer the patient to tertiary care
Like
center.
same thing, the rotational atherectomy, unprotected left main EF of less than 45%. Those are the state guidelines that you cannot do a PCI in your particular center.
Without surgical backup.
So that now this case has to be transferred. So those doctors will come and will do the PCI at Mount Sinai. So all of them have a privileges at Sinai, and that's where this patient will get the PCI. So the 85% of cases, maybe even a little more, nowadays getting PCI in the non-cardiac backup surgery places. But clearly, this kind of patient will come to the parent institution for getting the PCI. What do you think?
Good.
Yeah, I think looks good.
Go up.
8, 10, 12.
What stent
14.
is this?
This is a 3.032,
Which one?
Romus Premier. Down.
Go up again. Second.
Samin, there are obviously significant issues of using
That is a 4.012.
plaque modification here, but this kind of a patient in the future will benefit from a BVS?
Well, the particularly
relatively younger patient.
Because of the young age, yes. And it's not clearly the only issue remains which we need to see that these kind of cases, that what will happen in the subsequent trials, which clearly our Absorb 3 has completed. Now we are, they're planning to do Absorb 4, little more complex cases, and where it will come out to be. So even if it seems to be there, some data have come right now that maybe a slightly higher stent thrombosis in these patients with the
Do you want
absorbed
to put
stent.
a distal stent?
Yeah, I would
think we
think
should
2.520.
2.5, yeah, perfect.
2.520. In those particular cases, but key is that the clear distinct advantage that in this case, after 2 years, after 2 years, that this patient will not need, will not have any metal in his body is very reassuring here to advanced wire.
How are you planning to follow this patient?
Oh, this patient we already spoken that he is coming back for an angiogram in the beginning of the year. For follow-up angiogram unless something happens beforehand, but angiogram at that time.
2520, no?
Now we can play here, play the angiogram so everybody can see.
To our viewers, any questions you have,
we can give it a gap on the diagonal, right?
Please keep sending. You can also post your questions on the archived cases. And remember to watch our companion website on the peripheral interventions. The next one is August 27.
And the next month is our on 16th. September 16th.
Yes, that I always announce at right towards the end.
But we also planning actually October 12th. We'll have a second Tuesday. We'll do a structural heart disease case. So third Tuesday is our coronary. And the second Tuesday, we plan to start our structural heart disease as of October. We need to prepare things, and lot of planning takes place before we do these cases. So we are in that process now.
Excellent.
No, 2.5.
27520 is good. Is it 2.524?
Yeah, I thought that may be a...
You need 24 you want? It's too long. Yeah.
24. Yes. Oh. Yeah. 24, I think we had to cover that area. So that we are using now 2.524 Promus Premier. Now, one thing we saw very pleasantly in the Promus Premier, that the issue of the longitudinal foreshortening, the stent deformity, has kind of completely taken off, has disappeared, which was the concern in the earlier Promus generation. So this has been very good news. And of course, there's whole issue about the better tensile strength of the platinum chromium, better opacification. All those advantages come with it. No, you need to do PTCA first. Okay, give me a 2.515 balloon. Take it out, take it out. Don't even push. Take it out, take it out. 2.515 or 20 balloon, high pressure. Yeah, so clearly that was a very significant lesion. As you pointed out, because more and more when we were seeing, we were thinking about that lesion also. So rightly so, in this particular case, you want to take care of all the lesions which are significant, and that where your stent does not cross tells you that yes, it's a very significant lesion. Actually, if you go back and did we see that on the OCT at all, or the OCT did not go that far?
No, we didn't go distally that far. Samin, your fellows are in already for this is the end of their second month.
Yes.
How
they're doing very good.
Are you formally encouraging them to do more transradial cases?
Yeah, well, yes, and actually one of our attending who was transradial, who went to Chicago, is coming back. Nitin Barman, hopefully he'll join in next few months. So that transradial, we are telling these kind of cases. This is actually RCA total occlusion. I did it by radial. In this particular case, the first intervention I did radial and discharged the patient home same day. We did at 8 p.m. and patient went home at 1 o'clock. By radial intervention, but now here because the Impella and so needed. But the radial, but yes, these are the kind of cases, obese patients, groin tortuosity, little edge, that better to do by radial, no need to give and die, So this is, we have opened it, now we go back.
We've not addressed the issue of radio contrast media. What is your preferred agent?
Well, I mean, it's the same. I think what has become that iodixinol versus iopamidol, which is what we use here in all our OptiRay compared to Visipaque, and it basically, even the latest guidelines put all of them in the same category, that there is no additional advantage of the Visipaque, particularly even in the diabetic patient, because in our CARE trial, the total diabetic patients were 184. The nephric trial, which led to the initial recommendation of iodixinol better compared to basically Omnipaque, was based on 110 patients. So clearly we see no difference in diabetic also. So we use in all our patients, and iopamidol and is working out very well.
What's your distribution today in the cath lab between OCT and IVUS?
Anno will probably give it a better.
Become almost equal?
No. Since the indication, clinical indication for intermediate lesion, if you have to do any PCI, in the guideline is still IVUS. So, but in situations where like this one, where you know there is a ruptured plaque, you want to have a diagnosis of that, and of course we have a lot of trials. I personally have 3 trials that we are doing with imaging. For these cases, I will use OCT.
And near red?
Near infrared has now initially used to be only the LipiScan.
Yeah.
And but now they have the IVUS catheter incorporated into that.
I can
so
clearly tell you
use
much more flow in the diagonal.
Yeah, all of them looking very good.
You are looking much larger vessels, and I think once the wire is out, you'll see better flow in the distal LED too.
Also, yeah, and then we'll do a little vessels. We get a 4:12 now.
Left main time.
Yep.
So this is where there have been a couple of questions about mandatory to put a wire in the circumflex given its large size.
Yeah, we have the fielder wire. We'll just.
No need. Okay.
Now, one thing for sure, what we learned now, that once you have a large stent and your ostial of the circumflex remain okay, or vice versa, that if there is no need for routine kissing balloon, because that kissing balloon will destroy, deform some of your stent, and patient come back with restenosis.
Right.
There is a great flow. You don't need to do a kissing balloon. If you put a 2 stents, you definitely have to do a kissing balloon, but not otherwise.
Only question is, we want to cover the left main ostial LED.
Yeah, we want to cover.
Okay, then why don't you? Then 1 minute. Then maybe you need a longer one. Take a cine.
Let's see this one.
Leave a gap, right?
Should have been.
Yeah, that's okay.
Okay, here. That's good.
Okay, let's see.
It's a 4-0.
Yeah, I think you're good.
Yeah, very good. Go. Okay, now this is the
time where you know.
Money time.
Impella.
Where the Impella. Go to 16.
Go down.
Negative. Go up again. For this few seconds, now he does become tachycardic.
Yeah.
The pulse rate from 56 become like 80, 85 now. Good.
And, down. And I think the pressure drops by.
And pressure drops about by 20. 10, 20. Now we can have a 4.5 high pressure balloon.
Okay. Cine.
Wonderful. Looks to be some lesion displacement into the circ, or maybe just this view. The flow.
Yeah, remember last time also we did the FFR on that side lesion.
Yeah. Side branch. That's the way the side branch will look once you place the stent.
Place the stent, and we'll go to some other view, because that basically you need to determine.
We have the OCT
going into some other view.
Stent perfect placement looks perfect in the left main.
Now you want to dilate with a 4.5, or looks very good? We can use a 4.5 there.
Actually, nothing wrong. You can do the OCT, which will tell you how much is your.
Let's do the OCT first.
Stent expansion.
Yep.
Samin, another question for you. What is going to be the long-term antiplatelet strategy?
Yeah. The patient is on what?
He's on Plavix.
Yeah. Which clearly in this case, you want to do best possible strategy, best possible treatment percutaneously. That's what you had done, and also antiplatelet therapy, because even if they are a non-responder to clopidogrel could be an event. So in this kind of case, we tested this patient, on clopidogrel, and the patient has a
12.
PRU of 131.
How much, 12?
So clearly, in my opinion,
14.
no need to change antiplatelet therapy to more aggressive agents.
What range would you keep for the PRU?
Yeah, well, I mean, again, anything less than 230 is okay.
So this is perfect.
Yeah. Yep.
300 good.
Yeah, so in this case, I would try to continue at least for a few years, not our routine 1 year only. Actually, matter of fact, this patient has been taking the clopidogrel right from the beginning. Yeah, they have never stopped it. Okay, now we are here. Ready?
Yeah. Wait. Connect the OCT.
I put it underneath here.
In-stent, right?
Yeah, we know. The thing is, we won't be able to cover everything.
Then I want to see the left main.
Yeah, we'll able to get. We'll get the left main.
Yeah.
But the distal stent we won't be able to
That's
see.
okay. That's not a problem because
One
the stent
second,
has been
one second.
expanded. I want to see the left main only. Better. You want to pull back a little bit.
Yeah, but may not get so much. You need little dye.
Okay. You want to see? Good.
Okay, we are ready there. We are ready. You are good?
Okay. Get to the OCT.
Yeah. You can take a cine.
Please check.
Guide out.
Now this is what happens is the same thing. Now that we've dilated everything, we still gave only 4 cc dye. How much? That's why you see some swirling. How we got the left main, right? Let me see.
Go and see it. Yeah, go. You take care here.
That's left main. This is the left.
This is the left.
photo.
So this is guide.
Guide.
4.5.
This is
That's the
Yeah.
proximal left main.
So if you see, this is the guide. Then you have your left main,
that's
and
the
this is
stent.
a stent,
Yeah, looks well expanded there.
well expanded.
Yeah. So what?
And then here is our circ. You can see the circ coming in.
Get it up a little bit.
Just here. See that?
Left main we can see.
I said you don't need to post dilate.
Yeah.
Yes.
This is your left main.
Yeah, that's the left main.
Beautiful, yeah.
Going to move the camera.
The vessel got so large we didn't have enough contrast.
Now you see the stent within the stent here. Can you? We can appreciate the double layer of stent. Double layer of stent here. You can see the double layer of stent.
You happy with the expansion there?
Yeah, beautiful.
And a position.
Stent apposition is nicely opposed.
Oh yeah, it's good.
Which one is a branch? This one.
Okay, so we can complete here. Anything else you want to teach on that side, Anu?
No, we are good here.
Okay.
This one we are just
Anu,
trying
the
to see.
next question is the Impella has done its job, but does it come out now?
Yeah, absolutely. Now,
Yeah,
see,
it's already being weaned down.
I'm sorry. Let's go to the angiogram now.
Give me the.
This is basically you see nice. See the distal vessel now.
Looks perfect.
Now again, remember this case has an anterior wall MI. There is a significant anterior wall dysfunction, so that may be contributing not to a complete filling, but still now has improved significantly. No dissection. All the branches are patent, as you can see here, and this is what we have in the RAO caudal. So beautiful results. Everything looks good. We are going to just take the Impella out now, and
Take this out.
A very nice blush effect there.
yes.
Anu, what does an institution do if they want to use an OCT but don't have the assist device? Any practical tips?
Yeah, I think they come with a special syringe. You just have to do some weights with your hands, and you have to go. Yeah, that's it. We used to have. I mean, we started with using those syringes, but now since Yeah. 20 cc syringe. You have one of those? We can show it. They come with that special syringe. You just have to get used to it. But you see the pictures you get with the assist. Yeah. I mean, it takes a little practice, but otherwise, once after a few cases, you'll be able to do that.
All right. So let's come back to the point now. We just come and sum it up. That updated role of FFR and in PCI and stable ischemic heart disease guidelines, that the randomized trials incorporating FFR guided PCI have shown lower MACE, MI, TVR rates, stent usage, but no impact on survival except one data from Mayo Clinic did have. But recent long-term registry data also could not substantiate reduced mortality in FFR guided PCI. Only one anomaly there is that we have data from the Mayo Clinic, but overall it seems to be that it does by decreasing the stent use, lower MI and lower TVR. Second, that CABG now is the class 1 indication for multi-vessel CAD in diabetic patients, 3-vessel or complex 2-vessel CAD with high syntax score 22 and above and suitable for Lima graft, and patient is acceptable surgical risk. If this patient is unacceptable surgical risk, then PCI is okay. And more important, the heart team approach in deciding final revascularization in these complex CAD patients is appropriate. Some of these patients may benefit from PCI because they will elect to do so, and as we showed here, this complex case done beautifully, no complication, excellent flow, and we have opened the left main LED, mid LED, distal LED with excellent results with the Impella assist. This is what you need to optimize your therapy, and equally important, as you mentioned, that which antiplatelet therapy on long run. In my opinion, once you have taken care of acute complication and you know the PRU is less than is effective, that your clopidogrel is effective, I don't think it makes difference that you need to go with any other stronger antiplatelet therapy of prasugrel or ticagrelor. Now, I quickly go with the 3 questions that based on the recent updated guidelines of coronary revascularization stable CAD, CABG is preferred over PCI in following scenario, except 3-vessel CAD in diabetic, 2-vessel CAD in diabetic with distal LED lesion, 2-vessel CAD in diabetic with proximal LED lesion, 2-vessel CAD in diabetic with syntax score of 32, and 3-vessel CAD with mid LED lesion. Second question, following the true statement regarding FFR guided PCI except, these are the randomized trial that FFR guided PCI has shown to decrease mortality in randomized clinical trial. FFR guided PCI associated with significantly lower MI, lower TVR, and lower death, or significantly lower MACE. So basically, this is the question, which I'm sure we have gone through all the possible answers. And the last question is the FFR, about the FFR guided PCI in the Pan London registry, because that is one of the biggest registry data, long-term follow-up to 3 to 7 years. We have that FFR guided PCI was associated with lower mortality, FFR guided PCI is associated with significantly lower MI, FFR guided PCI is associated with significantly lower procedural complications, and FFR guided PCI is associated with significantly lower TVR, and FFR guided PCI is associated with significantly higher stent usage. And the answers will be available on our CCC Live cases.org.
Anu, final comments with you. I think this has been an excellent demonstration of doing a case very prudently and watching out to avoid any complications in such a complicated case.
I can just, I think, give you a few more, some advice on imaging, when to use what. If you have a borderline case and you're doing, you have to do imaging other than FFR for diagnosis as well as management of the patient. Since in the guidelines OCT is not included, you should probably use IVUS, whether any kind of IVUS, or even the LipiScan currently has IVUS, even if that is available, but you should use IVUS. But other than that, if you are you're going to do a PCI and you have to do some imaging to understand the treatment strategy, whether you want to do atherectomy or you can just do cutting balloon like we did here, OCT is a good tool, as we showed here. The important point that while you're doing OCT is that, one, if you have the assist device, you'll get beautiful pictures. Even if you don't have assist device, you can use with the syringe and do it. Large vessels, which is more than 4 millimeter, since you have to give a lot of dye load, you may not be able to see well. Small vessel which is less than 2.5, for the same reason, when it's too tight, dye washout, you may not see well in these cases. And the same thing, patient with high creatinine, you may have to watch out because you are giving extra 2-3 injections if you're going to do OCT in this particular cases. Otherwise, you see that one catheter with 2.1 second beautiful image. It's essentially watching a black and white TV versus a flat screen LCD TV.
Maybe even with the high resolution HD TV. Anu, excellent tips. Samin, congratulations to your team for performing a superb procedure, to the fellows too. We will see you next time on September 16th, and I hope this session has been beneficial.